Hi, I'm Dr. Tom Lewis, founder of RealHealth Innovations. I'm a medical scientist with credentials from the Harvard School of Public Health and a degree from MIT. RealHealth Innovations is a health creation company. What we do is we help people prevent, slow, stop, and reverse chronic conditions. Today I want to explain to you what we do on the far end of the spectrum with the sickest of the sick people, how we actually help people reverse chronic conditions. Now on the first slide, I'd like to show you that we're seeing exorbitant spending in healthcare, particularly in America, much higher in inflation. But the problem is we're not seeing the benefits of that spending. We still have rampant chronic disease in our country. Here's the next slide that shows you a comparison between the United States and the rest of the developed world, 36 nations that lead the world in economic development. America is to the far right, and the further right you go, it's more spending per individual, and we're kind of low. And the lower you go, the higher the mortality rates are for the population. So these Americans are dying much sooner on average. Our life expectancy is shorter than all these other nations. So what's going on? What's going on is we're not getting to the root cause of disease. So let's just look at the major chronic conditions. So if we look at heart disease, we've leveled off and we've seen a little lowering of heart disease, but we're starting to actually see an uptick if you look at the newest data. But we're way above where we were in 1900 on death rates per individual. Alzheimer's, rampant and escalating. Diabetes on the upswing, and we're not even measuring pre-diabetes, which is swinging up even faster. So rampant chronic diseases. This is a chart for a variety of chronic diseases on the rise. We're obviously treating symptoms. We're not treating the root. Let's just look at one simple case study, which is on the next slide. This is heart disease. So this is the CDC, the Center for Disease Control, publishing the rate of mortality for heart disease. And we're seeing, yes, there was a slight downtick, but now it's starting to go up. But let's look at the root. Pretty much the only thing we're doing to manage or prevent heart disease is look at cholesterol and then provide cholesterol-lowering drugs. Well, the number one cholesterol-lowering drug are statin drugs. They came in 1980. They were first introduced, and by 1990, 10 million Americans were on statin drugs. That's why I have this vertical red line. If you look at the change in heart disease mortality when statins were introduced, it's not even flinching. Statins really aren't changing the course of cardiovascular disease. Why I have this chart down here is this is a map of smoking rates in America. And what we're seeing is that there's a pretty strong relationship between that curve and this curve. So the fact that there's fewer Americans smoking is really what's going on in this heart disease curve, and it has very little to do with the treatments we're giving. And so if you look at what UCLA Newsroom is saying and Harvard Medical School, is many people, over half the people that have a first heart attack have completely normal cholesterol. So what is the cholesterol paradigm and lowering it doing for these heart attack sufferers? Absolutely nothing. We've developed a new model where we look at risks, multitude of risks, not just hypertension, not just blood sugar, and not just cholesterol. We're looking at 121 facets of risk. And we look at risks, what we do is for an individual, we give them a health risk grade from A to F. Then we measure health using biometrics, using a whole new way of looking at biometrics from a chronic disease perspective. Most of the blood labs we get today are looking at what is your acute state? Are you sick? Or what is your likelihood of being hospitalized very soon? We are looking at the blood labs in a whole new way. What is your prognosis in 1 year, 5 years, 10 years? And when you compare what we call our chronic disease temperature biometrics, looking at blood and future chronic disease risk, and compare that to our profile grade, what we're seeing is essentially a profound linear relationship. And what that's saying is the risks we're measuring, this way going to increasing risks, is intimately tied to your physiology as measured by biometric screening. And I'll talk about these special cases that I've highlighted over here in a minute. So our process for our advanced testing goes this way. We run a living profile, which is an online tool to measure your risks. We're measuring really your immunity. Every risk you add lowers your immunity and makes you more susceptible to disease. We want to know what that susceptibility really means in terms of the root cause of disease. The chronic disease temperature. We're measuring your blood labs. We're measuring objective measures of health and disease. We're measuring your physiology, your blood, and in some cases we're actually measuring your pathology because we include eye tests where we're actually looking at tissue and including that in our biometric screening. This is what we've concluded, and it's very fundamental. Next slide. Is your immune system and the strength of your immune system is really a predictor of your future chronic disease health. So let's just look at a simple curve. Death rates from influenza, the black curve. So we see very young in life, early in life, and late in life, we see an increased amount of mortality from the flu, influenza, vulnerable populations, immune system decaying, early on immune system developing and weak. What our goal is to help people improve their immune health and track along the green lines. But what we find is people who have poor immune health and a lot of risk, the people in our so-called C, D, or F category, their immune health really looks a lot more like this line. So all throughout life, they're susceptible to disease. And then people with reasonably good immune systems may experience a blip in the curve, if you will, by this, according to this red blip here. Might have been a car accident, might have been mononucleosis, a death in the family where their immune systems become compromised and become vulnerable. So these people stay healthy and drug-free for life and live a long, healthy life. These people may have some interference, particularly with chronic disease, sometime in their life. So on the next slide, I'm going back to our living profile chronic disease curve, and you can see the linearity. So we're very good at predicting where people fall on this health disease continuum. Now I'd like to talk about some of these special cases. So what we do in terms of our advanced diagnostics is we risk stratify the population. In that upper right-hand curve, here are some of the cases we have. Here's an individual with chronic fatigue, diabetes, mood disorders, elevated cholesterol, and 15 other conditions, diagnosed conditions. Here's a person with 40 conditions, including elevated cholesterol, diabetes, chronic fatigue. Here's obesity, cholesterol up, arthritis, 6 other conditions, depression, osteoporosis, chronic fatigue, and 5 other conditions, all chronic. What is the common denominator to these people? We evaluated them. They had a high number of risks in their profile, so a poor living profile grade. They had a highly elevated chronic disease temperature, and we look under the cover using advanced diagnostics. What we're finding is active viruses. These chlamydia pneumonia, rickettsial typhi, Lyme, these are intracellular infectious species that are now coming out to play and affecting the health of the individual. So let's look at arthritis, mycoplasma, toxoplasmosis, depression, osteoporosis, chronic fatigue. What we're finding all too often is a combination of bad living profile grade, so a lot of risks in life, and high chronic disease temperature, changes in their physiology. We're seeing a correlation between low-grade persistent chronic disease states that must be treated, and the cause of them, of these conditions, are these opportunistic, very seldom diagnosed or looked for infectious species, many of which are very treatable. Let's go on to a few more cases. Insulin-dependent type 2 diabetics, chlamydia pneumonia, mycoplasma, cyclomegalovirus, viruses, herpes zoster's up, more intracellular infection, Lyme disease associated with GERD, urinary tract infections, high cholesterol. Here's a Parkinson's patient with elevated toxoplasmosis, chlamydia pneumonia, and mycoplasma. The relationship between Parkinson's and toxoplasmosis is well published, but in in delivery of clinical care, seldom considered and seldom treated. So let's just look at some examples of post-treatment outcomes. So individuals who we've run a living profile on, they get a bad grade, a lot of risk, had a high chronic disease temperature, and had an infectious burden. So here's a person with a severe autoimmune disease, psoriasis, where this person could not wash her hands any longer and felt being in a trade was going to have to go on disability soon. And this is what happens when you treat the root cause of a chronic disease effectively, and over a 5-month period we've seen these kinds of outcomes. The next is the gentleman with rheumatoid arthritis. In this case, and in the previous case, there were no drugs used to affect this treatment. It was identifying the root cause, seeing the infection, realizing the burden, and doing everything we could to raise the health and quality of the immune system of the individual. So here's a person whose knuckles could barely be seen and could not bend their fingers. And at this point, 5 months later, the 62-year-old gentleman says he feels like a 21-year-old and can, for the first time in a decade, close his fist. So the summary of our chronic disease mitigation program, at the beginning I said we prevent, slow, stop, and reverse, mitigate chronic diseases. We measure lifestyle risks at the root cause, our living profile, and we implement a plan to methodically correct those risks. Each risk makes a significant contribution to the improvement in the individual health as it's removed. We measure changes in the body using our biometric screening, which is a rather unique tool, a very sensitive, I call it an amplification, a signal amplifier for chronic disease biometrics. And then we perform root cause diagnostics based on the living profile and the chronic disease temperature. And most importantly, when we find things, we treat them, and when we treat our patients, they get better.